On this episode of MRI Physics Explained. Whoa, hold up. I thought this wasn't going to be another physics lecture, Dr. T.E. Let's see, 1 second here. There we go. Hey everyone, I'm Tim. I'm a radiologist. We don't need these fancy intros because we're talking about a subject much more exciting than physics. Today, we're going to cover how to clinically interpret diffusion weighted imaging and the many pathologies that show restricted diffusion. And at the end of the lecture, we're going to go over a little problem-solving flow diagram I created that you can reference while at work. If you want to skip straight to that, click the corresponding chapter below and we'll put a link to the diagram for download in the description. Now, Dr. T.E. told me that you've already had an in-depth lecture on the physics behind diffusion weighted imaging and how we generate these DWI trace and ADC images. Link to that lecture is above if you need a refresher, but the quick summary is the image on the left, which we call our DWI trace image, sometimes also referred to as the B1000 or isotropic image, all the same thing, represents the average signal loss created by movement of our water protons. If we look at the B0 image, our image without diffusion gradients applied, you can see it's a poor quality T2 weighted echoplanar image. After we apply our diffusion gradients and average it all out, we get this DWI trace image and look at the CSF flowing within the ventricles. Where we have the most water movement, we get the most signal loss. So let's talk about restricted diffusion. In a sense, all the signal you see in this image is due to restricted diffusion, the fact that water does not freely flow within the brain parenchyma like it does within the ventricles. And this is our baseline, the restricted diffusion of normal, healthy brain tissue. So how do you think abnormal restricted diffusion will present itself on this image? What we're asking is how will decreased diffusion relative to the normal, healthy brain tissue affect our DWI trace image? If increased water movement, such as CSF flowing within our ventricles, causes signal loss, abnormally decreased water movement will lead to increased signal brighter than that of the healthy brain tissue, as shown here. But here's the million-dollar question. Does this bright signal we see equal restricted diffusion? And the answer is, no, it does not. Let me show you why. Here's the different DWI trace image, and we can see there is some lesion within the white matter here on the right side of the brain, and sure enough, it's abnormally bright compared to the surrounding healthy brain tissue. But this is not restricted diffusion. It's an area of high T2 signal as seen on this T2 flare image, a site of old injury that is now filled with scar tissue. So while it's true that restricted diffusion will be bright relative to normal tissue on our DWI trace image, abnormal tissue with high T2 signal can also be bright relative to normal tissue, what we refer to as T2 shine-through. So this DWI trace image is not enough. We need to calculate the actual diffusion coefficient for each voxel on this DWI trace image using the following formula. From here, we can apply a black and white color scheme to the calculated values, what we call our ADC image. Confusingly, the ADC image stands for apparent diffusion coefficient, but it's in fact the average diffusion coefficient for each voxel calculated from our DWI trace image. This reflects a true map of diffusion. By convention, the lower the value, the darker shade of gray we assign, meaning restricted diffusion will be darker than normal tissue on our ADC image as we see here. Conversely, increased diffusion will be brighter than normal tissue, which we'll talk about later. So to truly call something as displaying pathologic restricted diffusion, it must be both abnormally bright on the DWI trace image and abnormally dark on the ADC image. Going back to this example of the old injury, the only reason I could tell you it wasn't actually restricted diffusion is because it's not dark on the ADC image relative to the normal healthy brain tissue. So you may be wondering, why do we even need to look at the DWI trace image if the only one that truly matters is the ADC? Well, we'll see some examples that aren't so obvious on the ADC image, but more importantly, you have to be aware that there can be artifact on the ADC image. Let's take a look at these two images. What's cool is that we have two regions that are abnormally dark on the ADC image, here within the right frontal lobe and another more ill-defined region within the left frontal lobe. But when we compare the DWI trace image, you can see that only the region in the right frontal lobe is bright. The other region is artifact, so truly, the DWI trace and ADC images complement each other, and before calling something restricted diffusion, you have to confirm it on both images to avoid making potentially life-changing errors. One last important concept before we look at a bunch of examples. We need to know what the normal reference point is that we're comparing to in order to determine what abnormal restricted diffusion is. If the lesion is in the brain, it's easy. Our reference is the signal of the normal, healthy background brain parenchyma. But this gets a little more complicated when it's not in the brain, such as these skull metastases here. Should we still compare these to the baseline signal coming from the brain? If anything, these look less bright than the brain. So in these cases, I think the most important thing to recognize is the fact that there's abnormal restricted diffusion, period. There should be no signal coming from the skull as you see in the rest of the picture, and we'll need to correlate with all the other sequences to figure out if it's a benign or aggressive process. Also note, these are more easily picked up on this DWI trace image than on the ADC image, another example of how these sequences complement each other. One more example is this bright spot in the right lateral ventricle. Again, the important thing to recognize is that there should be no signal here at all. The CSF is completely dark, and the fact that there is any restricted diffusion is abnormal and must be explained. So now that we can identify abnormal restricted diffusion on our images, let's look at some pathologies which cause this phenomenon. But first, if you haven't already, please consider liking and commenting on the videos, subscribing to the channel if you find this content helpful, and check out our membership section for additional ways to support. So what pathologies cause restricted diffusion within the brain? Perhaps the most common etiology is due to dead cells from an acute stroke or other serious insult. When we say stroke, we're referring to the process by which blood flow is abruptly cut off, starving cells of much-needed oxygen, and this is commonly due to thrombosis from a blood clot coming from the heart or neck getting lodged in the arteries of the brain. If this clot is large enough, it'll get stuck in the proximal aspect of the vessel and cause what we call a vascular territory infarct, shown here. You know what? Let's look at real studies. We don't need to limit ourselves to a few pictures in this day and age. Okay, so we have our DWI trace images on the left side of the screen and the ADC images on the right side. Starting from the top of the head and moving towards the feet, you can see we have a large area of restricted diffusion within the left side of the brain. Notice how it conforms to the left middle cerebral artery territory, with complete sparing of the parts of the brain supplied by the left anterior cerebral artery and posterior cerebral artery. Let's take a look at the blood flowing through the brain in real time. This is what we call a digital subtraction angiogram, where we inject contrast directly into the artery and watch how it flows under active X-ray. In this normal example, notice how the blood flows up the left internal carotid artery and out through the anterior and middle cerebral arteries. Now let's see what happens when a blood clot blocks off the flow of the left middle cerebral artery. Notice how there is a cutoff right here, where the clot has blocked the vessel and is preventing blood flow in the artery, and now the near complete lack of blood flow in the left middle cerebral artery territory. This is how we get dead brain cells that conform to a vascular territory. Be aware that there are things other than blood clots that can do this, such as atherosclerotic calcifications that break off, as well as air if accidentally introduced into the circulation. We refer to these under the more generic term embolus, or emboli of more than one, meaning something that's traveled through the vessels and gets lodged in an artery or vein. So why does this cause restricted diffusion? Now, the reason why is likely multifactorial, and there are a lot of different theories on the mechanism of action, so take everything with a grain of salt. But I'll show you a common explanation that I think makes a lot of sense and is at least likely a major contributing factor. Remember in the previous lecture we talked about how cells are continuously burning energy to maintain the right amount of water inside them. What do you think happens when a clot blocks off blood flow to the cells, cutting off their energy source? If we could somehow zoom in on this area of the brain and look at the cells and their surrounding extracellular space, A drop of water might normally move about in a random pattern such as this. You get the idea. Now let's look at these cells that are dying from a lack of blood flow. What do you think will happen to the cell's ability to maintain their water balance? All those little pumps maintaining these gradients are going to be knocked out and water might rush in, causing the cells to swell up with fluid. How do you think our little drop of water will meander about the extracellular space now? It might look something like this. It'll be harder for this water molecule to move about, and its movement will therefore be restricted compared to the normal healthy brain tissue in the previous example, resulting in hyperintense signal on our DWI trace image and a lower diffusion coefficient on our ADC image. So this is how an acute stroke can present, one that knocks out a large vascular territory, and the end result is not pretty. Near complete destruction of the brain parenchyma. Keep in mind that as the stroke ages and becomes more subacute, the DWI trace and ADC images change at different rates. The ADC image is the first to normalize back to the intensity of the normal healthy brain parenchyma. So when we have abnormally bright signal on the DWI trace image and normal signal on the ADC image, in a pattern suspicious for a stroke, we know enough time has passed to where it is now subacute. Another form of stroke is what we describe as an embolic pattern. Technically, the first example was embolic, but when this term is used, it usually refers to when multiple smaller clots travel through the circulation into the distal arteries and into perforating vessels, causing more focal smaller infarcts. In this example, we can see tiny punctate cortical infarcts involving the left frontal and parietal lobes. As we move further down, more noticeable infarcts are seen within the underlying white matter. This region we call the centrum semio-valley, as well as the periventricular white matter, left basal ganglia, and subinsular region. As before, these infarcts are in a territory supplied by the left MCA, and if we look back at our digital subtraction angiogram, you can see that these regions of the brain are the very last to receive blood flow. This region right here being supplied by end perforator vessels. If a clot makes it this far, there's very little redundancy in terms of blood flow to these regions, and that's why we get these small focal infarcts. They are also not constrained to a single vascular territory either, as in this example of a patient with endocarditis and mitral valve vegetations that have broken off and caused infarcts through the posterior circulation. So these are two common etiologies that cause restricted diffusion: acute dead brain cells from either a large vascular territory or embolic stroke. What else can cause restricted diffusion? It turns out injured and dysfunctional brain cells also can lead to restricted diffusion, the first example being seizure. In this example, you can see there is very subtle restricted diffusion within the left cingulate gyrus, best seen on the DWI trace image, which connects with this known old treated metastasis in the left occipital lobe. This is a great example of, again, why you need to look at both the DWI trace and ADC images. It would be very easy to miss this if only looking at the ADC. Perhaps more importantly, we know this patient presented to the hospital for a seizure, which focused our search pattern on this case. You can see there's also gyral edema within this region on the T2 FLAIR images, another sign the cortex was damaged from a recent event. Now, why would a seizure cause restricted diffusion? Remember that the cortex is filled with neuronal cell bodies where most of the neuron's energy is produced and used. Let's again zoom in on this region and pretend these cells started firing uncontrollably, exhausting their energy supply. Just like we saw in the stroke example, these cells will now no longer be able to adequately control their gradients and water balance, and it's possible they could swell up. Now, unlike in the stroke, they're not all dead, but just partied a little too hard and need to sleep it off. Once again, our little water droplet will not be able to move as easily, causing restricted diffusion within that area. Let's look at another way these cells can be injured. Toxic and metabolic etiologies. In this case of opioid-induced neurotoxicity, you can see we have abnormal restricted diffusion within the centrum semiovale and periventricular white matter bilaterally, as well as within the splenium of the corpus callosum, scattered within the basal ganglia, within the right fornix and hippocampus, and bilateral occipital lobes and cerebellum. Let's take one more look at this and think about the pattern we're seeing. It's weird, right? Whenever you see a pattern of restricted diffusion that seems erratic, affecting multiple different regions of the brain in a somewhat random, disorganized pattern, you have to raise the question of toxic metabolic etiologies. So why would this cause restricted diffusion? As before, we've injured the cells, in this case from an injected toxic substance, making the cells sick and unable to perform all the special tasks they need to in order to function properly. Some of the cells may even die, or there may be an abnormal accumulation of molecules within the extracellular space. Regardless, the end result is going to be the same. Our water droplet is going to have a bad day and likely be restricted in its movement compared with the unaffected or less affected brain parenchyma, leading to increased signal on our DWI trace image. This is a systemic process, which makes sense why we see so many different areas of the brain being affected in a somewhat random pattern. Metabolic disorders can also present like this, both inherited and acquired, although the clinical history and lab tests are crucial into solving the underlying etiology. What's most important is that you recognize this atypical pattern and raise question of a toxic metabolic etiology so the clinicians can investigate further. Let's discuss a global hypoxic ischemic injury. This is another good example of why we need to look at both the DWI trace and ADC images. Starting with the DWI trace, you may find it at first difficult to spot the abnormality. But when we look at the ADC images, you notice this decreased intensity within the bilateral parietal and occipital lobes. Let's go back up to the top and slowly compare both images. You can see there is actually extensive, subtle DWI trace hyperintense and ADC hypointense signal, first encountered within the bilateral precentral gyri here, then within the bilateral posterior parietal lobes and occipital lobes as mentioned before, but also within the lateral precentral gyri here, and likely some signal abnormality within the bilateral basal ganglia and parahippocampal regions. Just to prove that we're not making it up, we can also see there's subtle T2 flare hyperintense signal within these regions as well, consistent with edema. Now let's think about this pattern of restricted diffusion. It seems to be bilateral, not conforming to a vascular territory, and involving the most metabolically active regions of the brain, the motor strip, corticospinal tracts, visual cortex in the occipital lobes, parahippocampal gyri, and these deep brain structures in the thalami and basal ganglia that are like little processors receiving and altering signals from other areas of the brain. And because these areas are the most metabolically active, they're also going to be the most vulnerable if the brain is suddenly starved of oxygen. That is the critical piece of history you need to know to make this diagnosis. The patient needs to have experienced a significant global hypoxic or anoxic event, such as cardiac arrest with prolonged chest compressions or hypoxia during birth. Knowing this history will focus your attention to this pattern when reading the study and make absolutely sure these regions are normal, as you can see how subtle the finding can be and also how difficult to detect if it's in a symmetrical distribution. So why does this cause restricted diffusion? Because we starve the cells of much needed oxygen, just like in stroke, except there's a wide range of damage that can happen to the cells with this etiology, all the way from something minor they can recover from to cell death. So this is a global hypoxic ischemic injury. That history is critical. Another cause of restricted diffusion due to cell injury can be from demyelinating disease. Now, this is an extreme case where we have what we call tumefactive demyelination, meaning it almost looks like a tumor, but you can see we have this ring of restricted diffusion within the left centrum semiovale white matter, with surrounding increased diffusion from all the products of inflammation. On this T2 flare image on the left and T1 post-contrast image on the right, there is a band of peripheral enhancement associated with the lesion with extensive surrounding edema. This turned out to be a special type of demyelinating disease called MOGAD, which stands for myelin oligodendrocyte glycoprotein antibody-associated disease. What a mouthful. So why does this cause restricted diffusion? If we zoom in, we have this process where our immune system attacks our own brain cells, killing some cells, creating debris within the extracellular space, and bringing in a whole lot of fluid. You can imagine the surviving cells aren't going to be too happy in this environment as well. And that's why we get this mixed picture of restricted diffusion along the periphery, corresponding to the active battlefront where we saw all this enhancement, and then increased diffusion both centrally where the brain has basically been liquefied, as well as surrounding the enhancement from all the products of inflammation. Anytime you see enhancing lesions with restricted diffusion within the white matter, consider active demyelinating disease, especially if in the classical juxtacortical, periventricular, callosal/pericallosal, or cerebellar white matter regions. Let's talk about one more etiology in this injured dysfunctional cell category. Prion disease, also known as CJD, Creutzfeldt-Jakob disease. In this example, we can see there's extensive abnormal restricted diffusion within the cortex through the left cerebral hemisphere, as well as within the left basal ganglia. Now be warned, this is a wildly extensive case, and depending on how advanced the disease is, you may only see this in the cortex of a few areas of the brain, or the classic hockey stick sign within the thalami, which we do not see here. Also, this is one etiology where you can see hyperintense signal on the DWI trace image, but not corresponding decreased intensity on the ADC image. The critical piece of information here is the history. These patients present with a rapidly progressing subacute cognitive decline, and that history should motivate you to spend extra time looking at the cortices and thalami for any bright signal on the DWI trace image. I'm not sure if there's a definitive reason why this causes restricted diffusion or sole DWI trace signal abnormalities, but you can imagine that the uncontrolled proliferation of abnormal proteins within the cell will lead to cell death and accumulation of protein within the extracellular spaces, both of which will affect our water movement compared to the adjacent healthy regions of the brain. Let's move on to one last category of restricted diffusion: that which is caused by abnormal cells or fluids. The first example of that is due to cancer, both primary neoplastic and metastatic disease. Let's take a look at this classic example of a primary brain lesion causing restricted diffusion. You can see there's abnormal restricted diffusion within the left frontal lobe, specifically the periventricular white matter near the left lateral ventricle body and frontal horn, with some involvement of the corpus callosum genu. There's also involvement of the bilateral basal ganglia, anterior inferior frontal lobes, and hypothalamic region. If we look at the T1 post-contrast images, you can see there is abnormal, homogeneous appearing enhancement within these regions, and a little bit of mass effect, but not a ton. This is the classic appearance of CNS lymphoma, an etiology you should always consider if there's a homogeneously enhancing mass with restricted diffusion within the brain. Now, why would certain cancers such as lymphoma cause restricted diffusion? If we zoom in on this region, let's say one of these cells mutates, or a cell from somewhere else in the body mutates and gets lodged here, and this confused cell starts multiplying out of control like so. Once again, you can imagine how it might be more difficult for our poor little water drop to move about this area of the brain now that it's packed full of cells. Let me show you one more case. Here you can see that we have abnormal restricted diffusion within the right basal ganglia, thalamus, frontal lobe operculum, and insula. You can see we have a lot of abnormal T2 signal on the FLAIR images and some subtle enhancement on the post-contrast images. This happens to be a glioblastoma, one of the many different ways it can look, so it's always good to remember this within the differential for a diffusion restricting mass. Lymphoma is not the only thing that can show restricted diffusion. Let's talk about some non-neoplastic sources of restricted diffusion. The first being blood. That's right, blood causes restricted diffusion too. In this example, we see large hemorrhagic contusions causing restricted diffusion within the anterior frontal lobes due to trauma. We also see subdural hemorrhage along the bilateral cerebral convexities. The nice thing about acute blood is that we can see it on many sequences, such as these FLAIR and SWI sequences. So why would blood cause restricted diffusion? Let's think about it. We're bringing in a whole different fluid that's not normally supposed to be there on top of the damage already done by this traumatic impact. Now, blood has a much higher viscosity than water. It's thick and becomes sticky, forming clots. And if you remember in the prior lecture, viscosity is one of the factors that determines the diffusion coefficient. Within these brain contusions, we get significantly elevated restricted diffusion. In these subdural hematomas, the bar is lower. Remember that we should see no restricted diffusion here at all, as normally there's simple flowing CSF here, so any restricted diffusion within these regions is abnormal and must be explained. A few more examples to wrap up this section of the lecture. Cholesteatoma. This is another great example of seeing restricted diffusion where there should be none. On this coronally acquired diffusion sequence, you can see a focus of restricted diffusion within the region of the left middle ear. Remember, there should only be air within this region, so there should be no signal at all like on the other side. If we now look at this region on a temporal bone CT, you can see there's abnormal opacification within the left middle ear eroding the adjacent bone, and this is from a cholesteatoma, which is a non-neoplastic growth of keratinizing squamous cells that produce inflammatory keratin debris that, you guessed it, causes restricted diffusion in a place where there should be none. Finally, let's talk about one more classic etiology that causes restricted diffusion, and a very useful one at that. Pus, or purulent material from infection. In this example, we see there's a prominent large area of restricted diffusion within the right frontal lobe with extensive surrounding increased diffusion. On the FLAIR and T1 post-contrast images, you can see this corresponds with a peripherally enhancing lesion with extensive surrounding edema. This combination of peripheral enhancement with striking central restricted diffusion is diagnostic of an abscess. Now be warned, there are other neoplastic and autoimmune etiologies that can show peripheral enhancement with central necrosis, but those typically don't have pus filling in the cavity causing such prominent restricted diffusion throughout, as seen in this abscess. As to why this causes restricted diffusion, again, we have products of inflammation, but this isn't just our own cells being attacked by the immune system as before. There's abnormal bacteria growing, destroying cells, and being destroyed themselves, creating one big mess that the body tries to wall off, leading to the formation of this abscess. So this is not an exhaustive list. There are many other things that show restricted diffusion, like epidermoids, but I think it's a good start. A quick word on increased diffusion. These would be areas that are brighter than the normal brain tissue on the ADC map, seen here surrounding our cerebral abscess. This may or may not be bright on our DWI trace image, and usually due to underlying pathology which is better assessed on the other sequences, such as our FLAIR image in this case showing all that edema within the tissues. And sadly, no one really cares about increased diffusion. Like I said, we can piece together what's going on here better on the other sequences and in conjunction with the clinical history. And maybe someday this will be a marker for something, but as it stands, restricted diffusion gets all the glory, so with that, let's go over this flowchart I made to help problem solve restricted diffusion in the clinical setting. We start with the clinical presentation, and notice that there are 3 etiologies that we've separated from the rest because the clinical presentation is so specific that the clinician should already have an idea of what's wrong, and the imaging is to assess the extent of involvement. For instance, the patient has an acute neurologic defect concerning for stroke, or the patient had a seizure, or the patient had cardiac arrest with prolonged CPR. Hopefully, this is communicated to you in the history of the exam, and once you know that history, you'll know exactly the pattern of restricted diffusion you're looking for. If it's a stroke, you're looking for either a vascular territory pattern of restricted diffusion or scattered embolic pattern. If it's a seizure, you're looking for abnormal restricted diffusion within the cortex and any associated cortical edema. And if it's concerned for a global hypoxic ischemic injury, you're inspecting those high metabolic areas of the cortex such as the periatlantic region, occipital lobes, hippocampi, along with the deep gray nuclei. If the history does not fit any of these 3 etiologies, and we see abnormal restricted diffusion, we have to do some detective work. So we're going to list all the other etiologies under altered/other. The clinician thinks that there's something wrong with the patient, they're not acting right, or have other nonspecific symptoms that requires imaging to help them figure it out. So an MRI brain is ordered, and we see abnormal restricted diffusion. The first thing to consider is, does the lesion look like a mass? Is it occupying more space than the normal brain parenchyma would, pushing on the adjacent parenchyma and causing mass effect, squishing the ventricles, or maybe the cortex so you can no longer see the sulci? Or is there none of that? Is it merely a lesion that may have some enhancement and edema, but from what you can tell, isn't mass-like and doesn't seem to be pushing on the adjacent brain structures? Keeping in mind that, of course, a very early mass lesion may just be too small to exude much mass effect yet, but there are exceptions to all of these rules, so let's stick to the basics here. If you think it's a mass lesion, the next decision point is whether the lesion is what we call intraaxial, arising from the brain itself, or extraaxial, coming from the meninges, bone, or elsewhere within the intracranial compartment. If it's extraaxial, not arising from the brain itself, common etiologies that will display restricted diffusion are meningiomas and metastases, along with more rare entities such as epidermoids, and if the location is in the middle ear, cholesteatomas. This is an example of a meningioma arising off the anterior cranial fossa, a so-called planum sphenoidale meningioma. Notice how it's pushing on the brain from the outside, instead of arising within the brain itself. If we look at the diffusion-weighted images, we can see there is indeed restricted diffusion within the mass. But wait a second, let's go back. There's another finding here. What's this? There should be no restricted diffusion here within the skull. It turns out this person also had lymphoma metastases to the skull, a good reminder that you always need to explain restricted diffusion no matter where it is. For the intraaxial masses, there's a couple patterns to consider. The first is a lesion with a peripheral pattern of enhancement. A high-grade glioma, such as a glioblastoma, often appears this way with an aggressive advancing front of enhancement as seen here. Notice all the mass effect associated with this lesion. This is the traditional look for a glioblastoma, but keep in mind there are atypical forms such as in the earlier example we saw that was more infiltrative and with more subtle enhancement. Also keep in mind that confounding case of tumefactive demyelination, although this is not the common presentation of demyelinating disease and pretty rare. This also has substantially less mass effect than you'd expect for a cancer of this size, and the restricted diffusion is oddly ring-shaped, following the shape of enhancement we see. The other non-neoplastic peripherally enhancing etiology to consider is a cerebral abscess. However, there are a few key features that differentiate this from most neoplasms. The first being that these will pretty reliably show avid restricted diffusion within the cavity as seen here, because the abscess is packed with bacteria or fungal cells along with pus and debris. Also, these patients will be sick. usually with positive blood cultures and other signs of rip-roaring infection on physical exam and labs. To help further differentiate, bacterial abscesses are typically larger and solitary or limited in number in varying distributions, while fungal abscesses are typically smaller and more numerous, often popping up peripherally near the junction of the cortical gray and subcortical white matter. Other neoplastic etiologies can produce mixed patterns of enhancement. You could do a whole lecture just on those, but if you see a lesion with avid homogeneous enhancement and restricted diffusion, this is the classical appearance of CNS lymphoma as we previously saw. Let's now cover restricted diffusion associated with non-mass-like lesions. And this is more difficult as there are many different patterns and etiologies, so we'll organize this by patterns. Let's say you open a study and see odd, non-mass-like restricted diffusion. If it's in one of these weird patterns that appears random, involving the cortex, basal ganglia, thalami, possibly mammillary bodies or pons, and with bilateral involvement, think of toxic or metabolic etiologies, another subject that deserves its very own lecture. If the restricted diffusion is associated with a process that seems regionally centered within the mesial temporal lobes or limbic system, you have to consider HSV or limbic encephalitis. If you see a restricted diffusing lesion within the white matter in the presence of other white matter lesions in locations characteristic for demyelinating disease, such as the juxtacortical, periventricular, callosal or pericallosal regions, or within the infratentorial white matter, consider demyelinating disease. Also look for additional involvement of the optic nerves or spinal cord. If there are random multifocal lesions that display that characteristic homogeneous enhancement, consider lymphoma, which can present both mass-like and non-mass-like. Lymphoma is one of the great mimickers. You can almost never go wrong suggesting it with any weird enhancing and restricted diffusing process. Finally, if you see weird cortical-based restricted diffusion, or a hockey stick pattern of restricted diffusion within the thalami, consider prion disease, CJD, remembering that sometimes this can present as DWI trace hyperintense signal only without discernible decreased intensity on the ADC images. Also, this must have a history of subacute progressive cognitive decline, which typically tips you off to look real hard for those diffusion abnormalities within these regions. If you find this all overwhelming, the good news is that because restricted diffusion associated with these non-mass-like lesions can be so varied in appearance, these findings will always need to be correlated with the clinical history, labs, and almost all will need a lumbar puncture for CSF studies. One last little warning here. Always keep in the back of your mind that subacute infarcts can both enhance and display restricted diffusion, and can therefore mimic any enhancing multifocal pathology, the most concerning being things such as parenchymal metastases, fungal abscesses, or autoimmune processes. I've seen cases in cancer patients called metastatic disease when in fact it turned out to be subacute infarcts, and you do not want to change someone's cancer treatment on an incorrect diagnosis. On the next episode of MRI Physics Explained, we kick it back over to Dr. T.E., who will walk you through this thing called diffusion tensor imaging. Consider following us on social media, liking and commenting on the videos, and please subscribe to the channel. It really helps us grow and make these videos available to more people. Thanks again for watching. This is Dr. Tim, the radiologist, leaving now.